I'm going to be presenting a presentation. We've called it the Dandi March, but I won't be telling you why just yet. But wait, I will tell you why in a little while. So basically, it's a case of 61-year-old Mr. Ranjit Chatterjee, who presented with a 4-year history of tremor in both his upper limbs, as well as a more recent history of frequent falls, gait disturbances, and cognitive impairment. He presented to OPD, was assessed, and then he was admitted, and then we got to assess him further. So basically the tremor it was mainly a resting tremor, but there was some element of intention to it. For instance, when he was performing fine motor activities like writing, there would be more of a tremor, but not so much when he was taking a cup and drinking or something like that. He had a history of frequent falls. There was no preceding syncope or no preferential fall to one side. It was to any side. He would fall out of bed sometimes. He would fall when he's sitting down. It was very uncharacteristic for any specific pathology. He also had this cognitive impairment that his family described of progressive loss of memory, short-term memory mostly, and he also had some kind of episodic where he's not able to name common things, like for instance, he doesn't know that a mobile phone is a mobile phone or a table is a table. He calls it something else. And then he had this gait disturbance as well, which we'll go into, and kind of similar to a Parkinsonian gait, but he also had some kind of shifting of his own weight to prevent himself from falling by his own explanation. And all of the symptomatology was episodic, as in it would happen maybe in a month. There would be 1 week where he would be okay, and then a couple of days where he would have very severe symptoms, and then a few days where it would just be the tremor, or just be the falling, or just be the gait. So it was very interesting. And he also had this history of an RTA that was just before the onset of the more severe symptoms. So obviously the tremor he had for a long time, but this RTA, it was essentially he was riding his bike, fell down, hit his shoulder, didn't hit his head. He was wearing a helmet. He got up, rode himself back home, and continued for the next 2 weeks or something without any sort of abnormalities. There was nothing acute after the RTA, but for his shoulder, he was taken to hospital and assessed, and then they found him to be severely hyponatremic there, and he was given correction, and everything seemed to be fine. So his past history, in general, he has a 25-year history of bronchial asthma, 9-year history of diabetes, 8-year history of hypertension, and recent history of benign prostatic hyperplasia, and then there's the RTA. So he's had that one previous hospital admission for the hyponatremia. And then just a personal history of various addictions. He quit smoking like 15 years ago. He was a BD smoker. And he also has this heavy use of oral sedatives, which he's not able to tell us what drugs he was using, what the name of it is. He didn't have the drugs with him. Nobody in his family knew what the drugs were. But we do know that he had some very heavy drug use, as well as pan and chewing tobacco. So on examination, his vitals were relatively normal. JVP was not elevated. He was afebrile and comfortable, well hydrated, no signs of dehydration. His cardiovascular exam was normal, respiratory also normal. Some slight increase in liver size, possibly due to fatty liver. He also described some moderate alcohol consumption, which could have been more than that. And then his CNS exam is where we were interested. So we did a mini mental state examination and found him to be just on the borderline, kind of classified as mild cognitive impairment. He had no cranial nerve abnormalities. There was cogwheel rigidity was a little bit of a question mark, because in OPD when he presented, the consultant who evaluated him found him to have cogwheeling rigidity, but then he didn't have it in the ward. Grade 5 power in all his limbs. Reflexes were absent in knee and ankle, but that's typical for a diabetic. So, and sensory also was typical for diabetic, except that it wasn't bilateral. So then he had some cerebellar signs. The finger nose test, he had some mild pass pointing at some points, and then this tandem walk also was affected. So essentially, at the end of the examination in history, we put him in a sort of extrapyramidal / cerebellar.
Hold on a second. Do you have any final years here? Just the one. When do you analyze the symptoms and tell us what you think, where's the anatomical localization of the problem?
'61. 61.
Three months, no? Symptoms?
Yeah, 3-month history. I mean, there's a tremor from before, but...
Do you want to just summarize the history
Sure,
and examination findings?
So essentially it's a 61-year-old male with 4-year history of tremor and 3-year history of falls, gait disturbances and cognitive impairment. His physical findings are only significant for some mild cognitive impairment and a few mild cerebellar signs.
Anatomical localization will be to a basal ganglia, I think, because of the tremor predominating young onset disease. Like a atypical Parkinsonism, frequent falls, PSP, but it's examination wise we couldn't find any supra-gaze palsy, so or dysautonomia because of MSA, multisystem atrophy. But yeah, multisystem atrophy with cerebellar type is what I will think because of the cerebellar signs seen in the examination. But this is hyponatremia rapidly being corrected. Dandi March, I'll make it central point and myelinolysis as one of those also.
So it doesn't look like one part alone is a... Anything to add? Can you summarize once more for our one more final year who's here?
Sure. So basically, a 61-year-old man who has a 4-year history of intense resting tremor, plus 3-month history of frequent falls, gait disturbances, and cognitive impairment. His physical examination is only significant for CNS findings of altered mental state, MMSE 21, and some cerebellar signs, some path pointing, and some tandem walk affected. That's all. And maybe cogwheeling possible.
So cerebellar symptoms and also this LPH and all because he present with gait disturbance and other
He
than
didn't
what,
have any incontinence or anything.
other than what Don already said.
So more than one axis you think is involved. What did you think?
So our differentials that we considered was considering the history of the 4-year history. The first would be a sort of vascular Parkinson's with multi-infarct state. Then also because of the history of hyponatremia that he had that was very severe. At one point, according to his daughter, it was 106. Then it needed to be corrected. So then we would also think about maybe some damage at the point of them correcting it. So osmotic demyelination can cause similar symptoms. And then also because of the fall that he had during the RTA and then the frequent falls that he had following that, there could be some chronic subdural hematoma which was missed before this. Obviously stroke, and he was on all of these cocktail of sedatives and sleeping pills that we don't know anything about, so there could be some drug-induced Parkinsonism. And then finally, he's not typical for a space-occupying lesion, but he does complain of some occasional headaches and things like that also. So those were the differentials. Can I continue? So our initial investigation really didn't reveal much. Most of the tests were normal. A few things that were just about borderline, like his electrolyte levels, calcium phosphate, cholesterol. He was on treatment already with atorvastatin, and then he had some B12 deficiency. They brought with them an outside MRI that they had done just the previous month, and it showed no significant abnormalities. So we were kind of stuck. We had this patient who had this very intense sounding history, who seemed to be very affected. His family was very frustrated at this point, but we couldn't find anything particularly wrong with him. And he was like, okay, here's a video of him that won't play here, so I'll play it here, where he's just normal walking around in the ward. This is how he walked when he came to us. This is his Dandi March at this point. So you can see there's no gait disturbance necessarily. There's none of the symptoms that we've been told he has. But at the same time, the history that we have is of him walking like this. leaning back, the short festinant gait, kind of reminiscent of a Parkinson's disease or some other cerebral cerebellar / problem. So we wondered what we could do to kind of figure out. This happened 3 months ago when he had that hyponatremia. That's when he had this gait disturbance, and according to his family, it happens episodically over. Since then, it's kept happening again and again. We just didn't catch him at a time when it was happening. So we looked at the sodium again. Basically, what had happened was that at this hospital where he had been treated for the hyponatremia in November, he had been placed on a diet that included 24 grams of extra salt per day. And that's what he was taking, which is what we think was stabilizing him so that he could walk normally. And so this is the timeline basically of what happened in the months that preceded this. So we decided to recreate that timeline where he was normal, he had normal sodium, basically normal serum osmolality, and we cut out his 24 grams of salt for 1 day. And this is what we got. Immediately we got a different picture, and then the next day we restarted the 24 grams of salt, and we were back up to normal sodium again. So all we needed was this one 7th of February picture so that we could diagnose him with SIADH. Essentially, it fit all of the criteria. He was euvolemic in appearance, not dehydrated, not overloaded. He had the right decreased plasma osmolality, the inappropriately concentrated urine, and the elevated sodium in the urine. And so we decided to pursue that further, looking at the kind of differentials for hyponatremia first, before we decided to jump into SIADH. So essentially we excluded hyperglycemia. Although he's a diabetic, he was well controlled with his metformin and glimepiride medications. He didn't have any acute or severe symptoms at the time. You saw the video of him just normally walking around, being fine. So essentially we had to go to the tests, and then we found the urine osmolality more than 100, urine sodium more than 30, and he was not on diuretics, so that led us to that diagnosis. We just had to rule out any hypothyroidism and any adrenocorticosteroid problems. And then we could further continue with our evaluation of SIADH. So causes of SIADH you can see listed here. So CNS disturbance we already talked about in relation to his previous problems. We had first evaluated for CNS disturbances, but since we were having this issue of SIADH again, we decided to repeat the MRI, and again found no significant changes, just features of some small vessel ischemic changes is normal for his age. Then we thought about malignancies, so we did a CT thorax abdomen, which showed some enlarged mediastinal nodes, some very borderline nodes, but nothing else, no lesions, only the normal things that are characteristic for a person with bronchial asthma history. Then we thought about drugs. SIADH can also be caused by several psychotropic drugs, which he was possibly on, we didn't know. But then at the time he was in this controlled environment, he could not take the drugs while he was in the hospital. But again, the drugs can have a up to 1 year effect on a person, so that option was still open. But there was really no way. We were continuing to try to find out what drugs he was taking, but it was, difficult. Obviously from his history we knew that he hadn't had any brain surgery, any transsphenoidal procedures or anything. He had no family history of this. He had a family history of the tremor, but nothing of SIADH or anything in relation to hyponatremia. HIV is not an option for him either, and then obviously there's always the idiopathic option. So at the end of this, we're still just kind of stuck. After the CT thorax came back with the nodes, since that was the only thing that we could find that was somewhat abnormal, we decided to pursue that. So we got in touch with PulMed to see about a EBUS biopsy of the nodes. Before that, we also did a lumbar puncture just to check for CNS infection, but that was also fine. We did a psych consultation. Patient was not doing so well being in the hospital, so that along with finding out what drugs he was on was part of the reason for that. So the CT thorax that we wanted to evaluate, it had this right paratracheal node that was 18 millimeters. And so PulMed decided that they could EBUS these nodes. And they did it. The first sign was that on rapid on-site evaluation, which is basically where they take the sample and then they smear it the way we do with bone marrows. And they're not only able to see the adequacy of the sample, but also they stain it with some HE dye, and they can see whether it's granuloma or carcinoma. So at that point, we already had some inkling that it could be carcinoma, and then a few days later, when we got the biopsy results, they were positive for small cell carcinoma, which, as you know, has neuroendocrine features that cause it to secrete ADH vasopressin. So yeah. Basically, just a quick background on that. That's the case. He's diagnosed. He's being treated right now with in Medonc, and he's continuing his treatment here at CMC. So 67% of all SIADH cases approximately are reported to be caused by cancer. So as soon as we see the picture, it makes sense to pursue that. 70% of them are linked to small cell carcinoma. So especially in a person with the smoking history that he has, asthma history, and so on, it makes sense to pursue it. Essentially, the cancer cell itself produces the same gene that is produced in our brains that secretes vasopressin, and that's why it does that. And the presentation of the people who have SIADH can look exactly like this man's did. Obviously, there's some, things that he didn't have, but frequent falling, the decreased reaction time, the cognitive slowing were all things that he had, as well as the tremor, something similar to ataxia, and so on. So I was just thinking about what we can learn from this, and reading up about it, we have all of these screening techniques for small cell carcinoma. We have X-rays and CTs and bronchoscopies and, invasive things and non-invasive things. We have blood markers. But we didn't try the blood markers in his case, but he wouldn't have been caught by an X-ray. His cancer wouldn't have been caught by a CT necessarily because there was no lesion. Sputum testing wouldn't have caught his cancer. So there's something to understand about the microenvironment that the cancer creates for itself that in this case was exactly what helped us, because it isn't just randomly that this cancer secretes ADH. It's actually trying to make a more pleasant environment for itself within the lung. The hyponatremia helps with that. It helps keep away the immune system. So we can do that. We can apply that to so many more cancers. We only know about this one, that it has this presentation with SIADH, but there could be so many others where the cancer cells are doing the same thing. So I think it's an interesting kind of road marker to guide us onto a road where we look at the way cancer actually thinks and try to get into more of that mindset as opposed to just the what do we see? Do we see a lesion kind of mindset? So yeah, thank you for listening.
I think that was a really, really well presented case. Thank you. I think that's I'm speechless, but I just have one question. You explained the gait of the patient, like this backward, almost falling back sort of gait. In your reading, did you come across why I don't agree with the fact that it's a shuffling gait, but that sort of gait, what did your reading tell you about? Why did he have that gait where he almost looks like the center of gravity has shifted backward?
Yeah. Nothing came across in reading because there's nothing like really, specific to this kind of symptomatology. All we have is a general picture of what it might look similar to. The only thing from talking to him is that he talked about how he purposely adjusted his gait to prevent himself from falling because he falls so many times, or he had fallen so many times. He had this sort of subconscious, adjustment to make sure that he doesn't. So that's the only thing I can, yeah.
Anyone want to add anything? The treating team or any questions? Did he have the road traffic accident also because he had that
No, yeah, we thought about that. We thought about the tremor, maybe that caused the accident, but it was just a freak, slipped off the bike kind of thing.
I think first thing we need to give her a bigger hand of applause for that very excellent presentation. And this man evolved, and in terms of ordinary OPD there was this whole thing about whether he has something extrapyramidal versus not. But re-examining him many times, we didn't find anything, and he was trotting up and down like this in the ward. And that sodium thing came out only when we kept on asking, saying, okay, what happened to that very low sodium? He wasn't on diuretics that we knew of. There was something happening that caused the sodium to be low, and that was the only thing we had. And his daughter is a TV journalist, so which may make sense for the videos she had taken, and she was very pro, because we kept on saying, it's borderline, but we'd like to do the next. This man got angry with us. He got very upset and said, I don't want any more tests. This is before the biopsy. And he was quite upset because we had taken off his sleeping pills, we had taken off everything, and he wasn't allowed to chew pan, nothing, like we were at. So, but she said, no, if it needs to be done, it has to be done. If you ask me, there was a proactive relative, a good history that we could evolve into, and the patient's temporal profile then spoke for itself. So it was a bit confusing initially with that gate thing, and we couldn't put it into. Yeah. So because he was walking normally here, but we had a sodium of 106. How does somebody's sodium go to 106? This is a man from the RTA fell down, hit his shoulder, picked up the bike, drove it home. So obviously he didn't hit his head at that time, I mean. And he said, I went to the doctor only because I had shoulder pain, not because I actually hit my head. So it's just a story in evolution. Of course, once he got the diagnosis, he and his daughter just came and stood before me, eyes full of tears, didn't say anything, and said thank you and went. We didn't get the diagnosis, but I'm hoping that he will do well. And so much for the borderline notes that we discussed 100 times whether we should do an E-bus for.
Can I say something else? I learned a lot about gut reaction. Audrey sir had a really good gut about admitting him. Not many people would have thought to admit him because he was completely normal. There's nothing wrong with him. All he had was a history. Samya ma'am had a really good gut, to pursue those nodes. We could have just said, okay, he was on some drug at that point and it happened and it affected him and now he has SIADH, whatever, it'll go in a little while or whatever. But everybody that was involved, even my registrar, Joel, he pursued all of these things. And I remember when the sodium fell and we saw the result, he was like, run, go get a urine sample, go. I ran to 06 West to get the urine sample and an ABG and stuff. So I learned a lot about, following your gut and doing things quickly and getting the right answer.